Good evening and welcome. My name is Alfreda Rooks, and I am the Director of Community Health Services and the Program for Multicultural Health for Michigan Medicine. Next slide, please. We want to thank you very much for participating in our virtual town hall, COVID-19 in the African American Community, Equitable Vaccine Distribution. This is the second in a series of town halls that are specifically focusing on the African American community. If you have questions during the event, please submit your questions for our panelists in the Q&A box on Zoom or in the comments section on Facebook. Your questions will be read anonymously. Next slide, please. Okay. This event is being recorded, and the video of it will be available on our website as well as the YouTube station for Michigan Medicine in approximately a week to 10 days. The information that we're presenting to you today is based on for educational purposes only. If you have any specific questions about your care or your health, please seek your local health provider or the local health department for more information. The sources of our information are from the CDC and from the Michigan Department of Health and Human Services. Next slide, please. It takes a village and a group to put these types of events on. And I am pleased to here today to represent our partners, but to also say thank you so very much for their support and their engagement as we do this most important work, providing education and information so that the African American community can make an informed decision about their health. All of our slides here list all of our partners, and so please, if you have an opportunity, to say thank you to them for their support. Next slide, please. It is my honor and privilege to be able to introduce tonight's moderator. Felicia Brabrek is the state representative of the 55th House District, serving her first term. She is a practicing clinical psychologist with a master's degree in clinical social work and over 20 years of experience. In the past, she has served on the Washtenaw Board of Commissioners and led the effort to create the county's first racial equity policy. Dr. Brabrek is proud to live in a community with her husband and 2 kids that reflects the values that she has worked hard to instill. Dr. Brabrek, Representative Brabrek, we appreciate you being here this evening. Thank you, and take it away.
Oh, thanks so much, Alfreda. Thanks for bringing us all together tonight for this really important conversation. I am really excited to introduce folks to our panelists. We have amazing experts here who we're all going to be able to hear from. You know, we have about 4 questions that we're going to ask everyone. And then we have a lot of questions that have come in from all of you. So thank you so much. We're hoping to get to as many of those as we can and to hear those answers from our experts who are here. So let me introduce our experts who are here with us this evening and who are going to share their perspectives on the vaccine distribution for our Black community, and one that we know that has been slow going and slow and steady. We're hoping that we're ramping up, getting more vaccines and getting them to the places where they need to go in our Black and brown communities. So first, I'd like to welcome Tony Denton. And Tony is the Senior Vice President and Chief Operating Officer of the University of Michigan Health System. He serves as an active member on multiple senior leadership committees in the health system. He also participates and serves on various community boards and health industry association boards at the local, state, and national levels. Tony received his bachelor's degree from Northwestern University, his master's degree in health services administration from U of M School of Public Health, and his law degree from University of Detroit Mercy School of Law. So welcome, Tony. Next is Alonzo Lewis. Alonzo is the president of St. Joseph Mercy in Ann Arbor and Livingston as well. Prior to joining St. Joe's in 2016 as Senior Vice President of Operations, Alonzo was the Vice President of the Women and Children's Services and Business Development at Beaumont Hospital in Royal Oak. He has participated in several community organizations, such as serving as a board member of the Washtenaw Health Plan, Glacier Hill Senior Living Community, and Hope Clinic. Lewis received both his bachelor's and master's degrees from the University of Michigan. Next is Dr. Tindey Thomas. She is an associate division head and internal medicine physician at IHA. She also leads IHA's Diversity and Inclusion Advisory Council. Dr. Thomas received her medical degree from Wayne State University School of Medicine and completed her residency at St. Joseph Mercy in Ann Arbor. During that time, she was recognized as Internal Medicine Resident of the Year in 2002. Her clinical interests include weight management, women's health, diabetes, steroid joint injections, and hypertension. Next, we're joined by Dr. Christopher Altman. He is a clinical manager for immunization for the Rite Corporation. He recently made a guest appearance on WTOL 11 to answer the public's questions on the importance of vaccines. He received his doctorate of pharmacy from Ohio Northern University. And finally, we have Washtenaw County's own Chuck Wilson. He is a community health promotion supervisor at the Washtenaw County Health Department. He has over 20 years of public health experience and has given hundreds of presentations to various groups in our county. Charles received both his bachelor's and master's degrees at Eastern Michigan, and he lives in Ypsilanti with his family. I'd like to welcome all of our panelists here today and thank them for being here with us. So like I said, we have 4 questions that we'd like to have all of you answer, and then we'd like to get to questions that folks have already sent in. And please, those of you who are out there participating and watching, please continue to send your questions to us. So the first question for all of you on this panel is, can you please explain to all of us the COVID vaccine distribution process for your organization? And how about, Tony, can we start with you?
Sure, thanks.
Thanks.
Before I talk about process, I want to talk about our structure. And everything we've done with the vaccination process has been following the state guidelines, including the different phases of vaccination. To date, we've vaccinated around 65,000 individuals, and our process followed the phase 1A, the essential healthcare workers, 1 and 1B. We started with the 65 and older, and we've been doing all that we can with great infrastructure, pending the supply of vaccine. So our distribution process has been tailored relative to information and doses received from the state, and then embarking upon a significant vaccinator workforce that we created with different sites around Michigan Medicine's and University of Michigan campus to enable vaccination of those that were eligible in those phases. We also have been partnering with St. Joe Mercy Health System and Washtenaw County Health Department in our overall process as the rollout has continued and as we've tried to identify different populations at risk.
Thank you for that. Alonzo, can you talk about how St. Joe's is rolling out their vaccine that they're getting?
I certainly can. Can you hear me? Great. Well, good evening, everyone. Our process has been fairly identical to what Mr. Denton just explained. We've been adhering to the state and CDC guidelines of vaccinating our essential workforce and then focusing on the age and at-risk population. To date, we have administered 24,177 doses, primarily of the Pfizer vaccine. We have, as Tony mentioned, we have partnered with Michigan Medicine and with the health department to ensure access to the vaccine. Just last week, we have formalized a collaboration with the health department and with Eastern Michigan University to transition our vaccine clinic from the main hospital to the EMU Convocation Center. We are dedicating 20 FTEs of resources to move our clinic to EMU to supplement what the health department has already been able to support. And our hope is that we'll get to about 1,000 vaccines a day administered through that collaboration with the health department. We are also looking at how we extend our program and services to the most vulnerable and to at-risk populations. We realize that we can't rely solely on an individual person to get to the EMU Convocation Center. So we are working collaboratively to establish some pop-up sites in our 48197 and 98 zip codes. And we're excited about our ability to do that. But we also realize that we've got a long way to go to ensure that, that those populations get vaccinated.
Thanks, Alonzo. I appreciate that. I feel like you're right. Everyone's saying we have a long way to go, but everyone is at the table trying to make it happen. So I appreciate that. Dr. Thomas.
Good evening, everyone. Thanks so much for having me this night. So as an organization, we initially have reached out to our patients 65 and older, so very similar to what other groups have been doing as well. And we initially reached out to patients through their portal, so MyChart specifically. We found fairly quickly that we were not going to be able to reach out to specific patients of color because a lot of them had not signed up for the portal. And so we then changed our stance somewhat and developed our equity dashboard, which has been very helpful. With this equity dashboard, we're actually able to reach out to patients of color and make sure that there is equity across the board as we send out specific tickets to our patients. And so that's been extremely helpful. We know that in addition to reaching out to patients through the portal, it's really important to reach out to them by way of phone as well. And so we have also begun robocalls because we know not all patients have easy access to the internet. So at this point, when we look at our population of patients 65 and older, we have about 70,000. We have administered 7,000 first vaccines or shots for those patients. And for patients that have received second doses, we're at about 5,000. So approximately 10% of our patients have at least received that first dose.
Thank you. And why don't we go to Dr. Altman, one of the pharmacy and private side. Can you talk to us about Rite?
Yeah, absolutely. Thanks for having me. And you mentioned I went to Ohio Northern University. Just so everyone knows, it's not Ohio State University, so there's no conflicts here. Ohio Northern, much smaller school, much different atmosphere. So thank you guys for having me on. I think the one thing we are as a pharmacy partner is a little bit unique from the way the vaccine is being distributed. We have a direct relationship and agreement with the CDC as a federal pharmacy partner. As such, we receive allocation directly from CDC. They tell us we have X number of doses, these are all yours, and they give us direction as far as where to go with those doses. So within our total allocation, we had about 7 jurisdictions that raised their hand and said, we would like Rite to be immunizing within our jurisdiction. Michigan was one of them. So I'm making all these numbers up, but let's say it's 100,000 doses. They would have said 20,000 of those go to Michigan. From there, the way we looked at it, one of the benefits of retail pharmacy and the private sector in general is we have a lot of points of access. We have a number of stores spread across the entire geography of the state. So we looked at it from a perspective of knowing the doses were limited. We ranked our stores using the SVI numbers from the CDC to say where are the most vulnerable populations where we happen to have a store. And so we put the doses in the highest vulnerable stores, knowing that that was where the point of access would be needed for these individuals. So we basically tried to say, let's dig deep into these communities, put the vaccine in them so that we can give that individual the closest point of access. So that's how we started our process. As we see more supply become available, we're going to continue to either increase vaccine at those locations or open up in other spots because we were not able to fill our entire footprint of stores in the state of Michigan. Knowing that we got our original allocation, which was around 20,000 doses, and within about a week we shot through that. We had a small hiccup because of the weather, as everyone did. So we've sort of been waiting for that to catch up, and we're starting again. Actually, as of today, we started revaccinating folks. So that's kicked off. We're we're doing great with moving through doses. We still recognize the need to be more thoughtful and more strategic with how we bring other communities in, because the one challenge we have, and I'm sure everyone's having this challenge, we opened in a vulnerable population thinking that was our goal, to give them that access point, but we're seeing people travel in from outside that community. So looking at what are some strategic partnerships we can start leveraging to say, maybe doing this in the store isn't the best case. Maybe it is a matter of, let's get the doses and let's go somewhere else, or let's set up a call center. Let's set up, rather than waiting for appointments, we call people and schedule appointments. We're testing, piloting, and trying to solve for all of that right now, to figure out what's the best way to get that vaccine in the arms that need it the most.
Right, thank you. Mr. Wilson, will you tell us what public health is doing, please?
Thank you. So I'd first like to thank Michigan Medicine and Alfreda and her staff over at the Program for Multicultural Health for spearheading tonight's town hall and for inviting the health department to be a part of this discussion. This is truly an example of organizational and community collaboration. So the health department is currently vaccinating eligible individuals who live and work in Washtenaw County. Now, the health department has built up a significant vaccination capacity and will expand as vaccine is more widely available. The health department has established one mass vaccination clinic, which Alonzo mentioned, over at the Convo Center on the campus of Eastern Michigan University, that actually has the capacity to provide 7,000 to 10,000 vaccinations weekly. Now, individuals can make an appointment via survey online, and I'll put the link to that online survey in the chat box. So, but for those who may not have access to that type of technology, we have an actual phone number that folks can call in order to request an appointment. And I'll put that number in the chat box as well. So the way the process works is that when an appointment becomes available, the health department schedules eligible individuals for appointments by mail or by phone. Now, if individuals are not currently eligible for scheduling, they're asked to wait to complete a request. So each week, all available vaccine is used to schedule appointments. Now, the thing to remember is that about half of those doses are needed for second doses, and the remaining half is divided to vaccinate those who are currently eligible. So right now we're following state guidelines, as is the other health systems and the other folks who have talked about their protocol as well. So right now we're dedicating 75% of vaccine supply to older adults, and then the remaining 25% for eligible frontline essential workers.
Thank you, Chuck. I appreciate it. And one of the things that we all have been working on, advocating for, is being able to increase vaccinating folks in our Black communities, and right here. And I know that we've had the question come in. I think it's for folks from all over our county, but in terms of being able to get Black and brown folks vaccinated. But I'm wondering if you all can talk about specific strategies about how to increase vaccination among the Black community, particularly in 48197, 198. Again, knowing that we have folks throughout the county, but if we can also focus on those zip codes to be able to get vaccines to people. And Mr. Lewis, how about we start with you this time?
Sure.
Thank you.
Thank you for that question. I think it's probably the most important question that we all need to continue to process and work through. Vaccine hesitancy, particularly in the 9798 zip codes, is certainly rooted in a lot of mistrust, a lot of doubt, a lot of concerns based on history. So we are thinking about that routinely on a daily basis. One of the things that we have decided to initially start with is look at our own medical record, identify those people that live in our zip code that we're talking about, and how do we proactively reach out to them telephonically, via email, via phone call, et cetera, and begin to have a conversation around the vaccine and encourage them to get an appointment. That's kind of our phase one strategy. We also have been talking with the Ministerial Alliance of Ypsilanti, and we realize that the church is the home of faith and trust in the Black community. And we are in conversations with that Ministerial Alliance about identifying a few different church locations where we can establish some vaccination clinics at that location. So we're excited about those two specific strategies, and we believe that we can actually scale that once we begin to get some traction. The other piece too is we can't rely on people, and I think I mentioned this previously, to get to one of those sites. So then the question is, how do we tie in transportation? And we're willing to make a commitment to be a resource for transportation, to get folks to churches, to get folks to the convocation center, or even to think collaboratively about how we get vaccine into people's homes.
Great, thank you. Dr. Thomas, can you talk from that inside IHA and how you're doing that?
Yeah, so we have a few new pilots that we've actually started. One on February 19th, I mentioned how we started some robocalls within two of our clinics, or actually one of our clinics right now. So with our Towsley primary care practice, which has the area code 48197, once again, we are reaching out to those patients 65 and older by call. And so far, we've actually reached out to over 500 patients. I think 550 total have been called, and we've been able to get 301 answers thus far. Out of those 301 patients that answered, 186 actually said yes, that they are definitely interested in obtaining the vaccine. About 37 had already received the vaccine. And so we're currently in the process of contacting those patients, making sure they're scheduled. And then if their spouse is interested in the vaccine as well, we're going to make sure that we schedule them for their spouse as well. So that is one specific priority for us. And then actually just this past Monday, we began offering vaccines at our neighborhood clinic, also area code 48197, right on site. So this is a huge patient pleaser when a patient can go in, see their primary care physician for that routine exam and actually obtain their COVID vaccine. That is definitely something that is, like I said, a definite patient pleaser. And so thus far, and this has just been for the week, we've actually had 50 patients that have already accepted that vaccine process. Our hope in the future is to continue to expand, so other locations that we will continue to have dialogue with include the Hope Clinic and the Corner Health Clinic as well.
Well, thanks so much for that. That's great. I've heard other systems doing that too. When folks come in for their regular, physicals, being able to get the vaccine right away, and folks seem to like that. So it's good to hear that that's your experience too. Dr. Altman, how about from your perspective?
Yeah, I think from my perspective, the win we have as a community pharmacy is when we're able to partner with strategic partnerships out in the communities. Because unfortunately, because we're retail and because we see so many people in and out all the time, always, and we don't have a controlled population that we know is always showing up for appointments. It is really, come as you are, and we want to control that flow. We are doing scheduled appointments for all the vaccines. By definition, that creates an inequity because those folks that don't have the savviness to get a scheduled appointment automatically are not eligible to get it. So we can do all sorts of things, and we've done this with call centers, we've done this with an online digital process, we've done it with outreach from the store. It still creates a barrier, right? Because there's a step you have to take before you can get the vaccine. So I think our win is to say, let's get enough doses so that I can go to the NAACP, or I can go to a local church, or I can go to a community center that we know is a hub for this population and say, come as you are, get here. If you can't get here, maybe I go door to door, whatever that looks like. Figure out how to get to those people and remove as many barriers as possible. Because that's what we're up against. We're up against a very limited supply of vaccine. And those folks that are highest resourced are the ones that are able to navigate that system and get it. So really thinking through, how do we get rid of all of that stuff in the way and just get those vaccines to those arms? That's what we're looking to do. And I think it's going to take us some time to get enough supply to start supporting that. And we have to sort of be creative until then. And we are doing that now. We're doing some outbound calls rather than scheduled appointments. We're doing an idea of how can we do this on a walk-in basis, having 30 people show up at the same time in a limited pharmacy. So we're definitely thinking through all of these things and making plans for the future.
Thank you. Mr. Wilson, it makes me think of, like for you and I, kind of our shared profession of social work and going to people, right?
Yeah.
And going to where people are to be able to get whatever it is, to have that back and forth. So talk to us about what the health department is really focusing on in terms of being able to get vaccines to our Black community.
Absolutely. Thank you. So and this has been mentioned earlier, we're going to use the strategy of pop-up vaccination clinics, not too dissimilar to what we did regarding COVID testing. And we'll continue to use that strategy. And this is mainly to strengthen the equitable distribution of the vaccines in coordination with state, health system, and community partners. So a few specifics about our pop-up sites. So there'll be targeted community locations where eligible individuals can be reached more easily. Now, examples include senior apartment buildings, schools, churches, or specific neighborhoods. Now, these sites may be open to the public or they may be closed. And I'll say why towards the end. Now, depending on vaccine supply, 1 to 3 sites will and can be planned per week to provide anywhere from 100 to 2,000 vaccinations per event. We also have what we're calling mobile vaccination teams, and our specific program is called Nurses on the Run. And these will be deployed to reach group homes, assisted living, and eligible homebound individuals. We're also working with our racial equity office to work with faith-based institutions and senior apartment complexes. Now, future releases will contain information where these sites are located. And earlier I mentioned, I talked about some of them may be public or they may be closed. And the purpose of this is that we want to work closely with site management or community partners to ensure that the people who live in the complex or the neighborhood are able to get the vaccine. In addition, I want to include a link in the chat box where organizations who wish to host a pop-up site and can take a survey and we can get their information in order to do that. And this actually, it's funny, this answer to this question kind of bleeds into question 3 as well.
Sure, it absolutely does. And we'll look forward to hearing, more from you about, kind of the other kind of processes that we'll be looking at to make this more equitable. But Mr. Denton, I'd love to hear from your perspective from University of Michigan, how are we going to get more vaccines to the members of our Black community?
Thank you. A number of our strategies actually have been identified, particularly with Alonzo Lewis's comments. So let me try to elaborate on a couple of particular points. We have engaged in webinars and town halls to try to communicate in a way that starts off with listening, to deal with the issues around hesitancy, and to acknowledge the fears and the anxieties, and to marry the science and the data in a way that helps to address questions that people have about getting vaccinated. So we've created public service announcements to put information out. As Alonzo mentioned, the Ministerial Alliance and dialogue to hear and understand the issues that are out there, and then to shape strategies that would mirror things that have already been said about mobile clinics, pop-up sites, trying to engage in vaccination clinics and church sites, and to let that be the back end. But we think the front end is creating the trust. And in addition to the anxieties that are based off of historical, we've learned that people have other concerns about the pace in which the vaccines came to market and the speed. And so we tried to address those issues from a science perspective, because scientists have learned and discovered how to do things differently. but still as effectively completing all the steps. So we've been trying to inform and educate to the best of our ability, and then to move on from there, to not overpromise and underdeliver, because that creates chaos and confusion as well. And as much as we want to be able to do all that we can as fast as we can, we find that misinformation becomes a challenge in getting people vaccinated as well, because they become frustrated with the process.
Sure. Thanks. I mean, of course, for all of us, I think one of our major goals is to reduce barriers, right? To be able to reduce those barriers, get folks where they need to go in the most seamless way possible. And so, with that kind of frame in mind, I'm wondering, if all of you can also talk to changes that can be made to the process. And you've alluded to it at different times, but we want to make this distribution process more equitable and really address head-on racial inequities and disparities, those in transportation that we may see. We talked about no access to internet, and so can we have a conversation specifically about addressing those barriers and lessons that you've learned, changes that you've made, changes that are kind of coming down the pike, again, all in the name of access. And Dr. Thomas, I'll ask you to start.
Well, we have an equity dashboard that we developed and has been very helpful in regards to making sure distribution was appropriate among our patients of color. When we first drilled down the data, when we first began this process, we saw that our Black and Brown communities would quickly be left behind if we weren't really proactive with that reach out to these communities. And so at this time, we've been able to determine kind of the right mix of tickets, if you will, that we're willing to send to our patients, once again, through the portal, and then obviously also through the robocalls. And so I'm really happy to say that at this point, we have equity when it comes to the number of vaccines offered and actually the number of vaccines given. And I think that's really important to highlight, because we have seen a fair amount of vaccine hesitancy among our patients of color as well. So I think initially about 60% of our Caucasian patients were saying yes, or saying that they were interested in the vaccine, and approximately 35% of our African-American community were saying that they were interested. And so the fact that we are now aggressively and proactively reaching out to those Black and Brown communities, like I said, it's nice to know that we are having equity in what we're offering and what we're administering as well.
Thank you. I know that our community, like so many others, has done intentional work around that vaccine hesitancy, whether it's, town halls or small group presentations or talking one-on-one with folks. But, I feel like here in Ann Arbor, I was just talking with a group from the Protect Michigan Commission to be able to get the vaccine out and distributed. And one of the small work groups that I'm on is the Black community. And I found out from other folks in our state that they have some vaccine, but they can only get about 20 folks to sign up. So that hesitancy is very real. In other places that I'm was relieved to hear, at least for us, we've been working on it, and it seems to be helping. So that's interesting to hear from your perspective. Dr. Altman, same question to you, please.
Yeah, thanks for the question. I think we just recently started vaccinating within the state, so we haven't had a chance to really dive deep into our data yet to see where we're sitting. I can see anecdotally, I'm sure we're not doing great, because we see it across most of it. I don't know that we're functioning any differently than anyone else. We are putting some efforts behind this to figure out what can we do. And I think when you talk about hesitancy, I think we really have to be hypercritical of what the reason behind the hesitancy is. And I think I heard it before, like having that dialogue and that listening portion of this, because even thinking today, when you start talking about some of these efforts to take the vaccine to the person, the vaccines we currently have on market are 2-dose vaccines, and they're not ideal for that scenario, because the transientness of someone going to a location or going to them makes it very hard to come back to them in that second round. And now we see another product coming on market that is a single dose, and getting some education behind that to really say, this is a great product if you want to go out and do a single dose, but it's got completely different metrics as far as how it was approved. So understanding what's the hesitancy? Is the hesitancy going to be around the vaccine in general? Or is the hesitancy around a single product of the vaccine? And thinking and talking through that with the group to really understand this may be a great product for this particular population that we're going to take the vaccine into. But how do we get their buy-in to it? And how do we sort of organize and solidify around that? I think that's something we're really going to have to start thinking about as we continue having these conversations, because we're currently in a 2 vaccine scenario. And for the most part, people think they're the same thing, like they're relatively similar to one another. Another vaccine is going to come on market, and we have to understand how do we fit that into this conversation, knowing that it's going to be a really great candidate to get people that are hesitant. And you get them 1 dose and you'll be done, knowing that that really may be great for this population.
Thanks for that. Chuck, what do you think? What can we do to address these inequities?
Well, thanks for that question. So what we've done is I've talked a lot about going into communities, African American communities, and I'd like to talk a little bit about what that looks like to answer this question. So since the pandemic started, we've hired a number of what we call, many of you all are familiar with this term, community health workers. And these community health workers are persons of color who've been hired, obviously, by the health department to work in communities of color. And so that's, and it's not just that we've hired community health workers, but we've been very intentional to hire African Americans who live in these same communities. And so what they've done is that they've assisted with supply distributions and pop-up clinics in these areas. The CHWs are able to reach African American residents who do not have, as we talked about earlier, computer access, or who don't really have a relationship with the health department in general. And the reason why this has been so important for us, because we get feedback from our community health workers, from community residents, particularly those in African American communities, about some things that we're doing right and some things that we're not doing right. And so we've been able to establish this feedback loop from people who live in the communities that we're trying to reach, and how our public health practice can, by messaging, by service allocation, by resource allocation, how we can do a better job to reach these communities. And there's this whole idea of trust building, and these essential cleaning supply distributions that are really spearheaded at the community level by our community health workers it meets a need, and B, it builds trust. And so we'll continue to use that model to really try to deconstruct the barriers, because these barriers were constructed, which means that they can be deconstructed. It's going to take time, and really time isn't on our side as far as COVID vaccine, but we're definitely up for the challenge.
Thanks for that, Mr. Wilson. Mr. Denton, what do you think from your hospital system's perspective?
Thank you. When the pandemic first began, a number of us, comparing notes, we came up with this: we're trying to build the plane while we're flying it. And that phrase has followed us through every chapter of this horror story. But we learn along the way how to apply it better. When it comes to what we tried to do initially, we try to come up with a process that we would say would be an equitable process, by having a randomized method for identifying individuals eligible within cohort to accept an invitation for vaccination. Our population is essentially 82% white, 10% African American, 5% Asian, and the remainder across other populations. And in the early assessment of our data, we found pretty clearly that African Americans were not being vaccinated relative to the proportion of the population. So we needed to make some adjustments, learning how to fly better. But recognizing that equality does not equal equity. And as much as we were trying to have a process that would be equitable and fair, we weren't hitting the mark in terms of the populations at risk. So we have made some adjustments, have become much more intentional with our communications to individuals in the 48197 and 48198 zip codes, being more proactive in our communications and reaching out either through those that are part of Michigan Medicine, access to the portal or telephone or other means, a village approach through the community ministerial groups to try to find many different ways to reach out and bring in. So we'll now have to, of course, to wait for more vaccine to come in, but we've created a different kind of infrastructure and approach to try to reach the goals as soon as we possibly can.
Thank you, Mr. Lewis. Can you talk about, from the St. Joe perspective, how you really want to try and address some of these racial inequities and disparities?
Yeah, thank you for the question. Not much to add, from what others have already said, but I reflect often on, our colleagues associated with St. Joe's. And it became very apparent early on that if you looked at our existing process and approach, who was actually signing up to get vaccinated and who wasn't, it was pretty clear that we had a significant disparity there. I remember this distinctly, walking down the hallway, coming across two African-American colleagues and just asking, have you had your vaccination yet? And they said, no. They actually looked at me like I had horns coming out my head. And I said, well, help me understand. And one person said, I'm uncertain specific to how the vaccine would work with my DNA. And I said to myself, I said to her, we can answer that question. Another one who was standing right next to her said, I had COVID 2 months ago, and I don't know if I have antibodies still, but if I do have antibodies, I don't know how the vaccine will interact with my body, given that I have antibodies. And I looked at her and I said, we should be able to answer that too. Those two instances just told me that, this is our colleague base is a microcosm of our community. And those two colleagues, basically represent, the lion's share of maybe what some of the concerns related to the hesitancy might be. So we've doubled down internally on how do we educate our colleagues and how do we find an intimate way to do that. So we've gone to departments where we know we've got a disproportionate share of African-American colleagues. We've taken an infectious disease physician. We've found nurses and techs that have had vaccine that are of people of color, and we've gone collaboratively to those departments, and we've just joined their huddles to have 30 and 45-minute conversations around the vaccine. So I think about, that intimate approach, and that just tells me that I think we need to double down on doing something similar in our community. Not everybody's got access to be able to log into Zoom or WebEx to be able to listen into this conversation. So how do we think differently to take that mobile vaccine approach that Chuck was talking about and take a mobile education approach out in the community to be with the right people to share the right message? And I think we're starting to do a little bit of that with the ministerial association, but I think there's an opportunity for us to scale that and do it more. And I think once we do that, I think we'll see an uptick and an uptake in those folks getting and having a desire to become vaccinated. And then I think about the opportunity to strengthen community collaboration so we can actually provide resources to Chuck to create a greater scale and greater reach to his mobile vaccination platform that he has already in place. And I think there's an opportunity for us to just step into that space of greater community collaboration so we can reach more people with greater scale.
Thank you. And we've been talking throughout this time about what each one of your systems is doing, but at different times you have all mentioned partners. And Mr. Wilson, I'd like to start with you and talk about who are the community partners who you're working with, and how do those partnerships, let's focus on equity again, how do being partners with those organizations help improve equity? Oh, Chuck,
So
we can't hear you. Oh, now
Oh, am I on mute?
We can hear you now.
Okay, great. So thank you, Representative Brayback, for that question. I'm going to answer that question in two parts. You all can hear me, right? Okay, great. So I'm going to answer that question with a program that has been in existence for a while, or a partnership that's been in existence for a while, and then a partnership that we are still in the planning stages of. The first partnership is our Community Voices group. Now, this group was convened back by the Health Department back in 2017. And the idea around this convening was to have community members who are residents of color, or at least the majority of the Community Voices group are members of color who live in areas where, quite frankly, the health disparities have been the highest, which is on the eastern side of the county. And the whole idea around our Community Voices partnership is for us to have a convening or collaboration of residents who have lived experience, who can provide direction to the health department on strategies regarding policy, resource allocation, and messaging. And I'm going to be very transparent here. This group holds us accountable. They let us know when our messaging or our strategies are on point, and they let us know when they miss the mark. And I think that's really important to have that type of transparency. It's not always comfortable to get unfavorable feedback, but it's part of having a true collaboration and relationships with community members who are the most disadvantageously affected by a pandemic like COVID. And then the next program that we're still in the planning phases of is called our Vaccination Ambassador Program. I've talked about that on a couple of calls. And our goal here is to identify residents of color who have lived experience. And the idea is that they receive COVID vaccine information training by local providers. And the outcome would be to hold informal informational sessions with residents of color regarding COVID vaccination. And the really overarching theme of this is that we have residents of color who can get factual COVID vaccination information by people that they know and they trust. And we're finding out that that is such an important facet of any community engagement, community relationship building, and quite frankly, trust as well. And so we've got a meeting tomorrow to talk about the nuts and bolts of this program. And also, just to add this to us as it relates to the Vaccination Ambassador Program, we're going to have a strong youth component to that, because some of the feedback that we received is that a lot of our adults who are currently in those prioritization groups are getting information from younger people. And if they're getting that information about COVID and vaccination from younger people, then I think that it behooves us to engage our young people in order to be able to get that factual information to the folks who are currently vaccinating and who will and who will also be future vaccinees.
Thank you, Mr. Wilson. Mr. Denton, can you talk about community partners and how that helps us address equity?
There is strength in partnership, consistency of message, unity of thought. And I think it also creates an efficiency that reduces duplication and potential confusion by having consistency of message. I think that with the scarcity of the vaccine, the health providers, Michigan Medicine, St. Joe Mercy, the county health department, and others, we've had to band together in order to reach out across the community with messaging in order to try and be prepared to make a difference. And I'm really thrilled that pharmacies are now part of the process to be closer to the homes of the community to create increased access. So we have a platform at Michigan Medicine that actually is led by Alfreda Rooks, our community health services program. One of the important tenets for us has been that we're continuing a message around diversity, equity, and inclusivity that is framed by our values at Michigan Medicine. So having a structure in place already to reach out to the community allows us to optimize relationships that have already been built, that then becomes an easier way to exact teamwork around the problem that we're facing here. I would also offer that in addition to local partners, we are focused also on state partnership, certainly with MDHHS, with the Michigan Health and Hospital Association, to try to align with messages that go across the state that are focused on certainly equity for vaccination, but health disparities in general, so that there's a knitting and not a need to reinvent the wheel, but to really create the central theme about disparities are all around us, and systematic racism is a public health crisis. And so we need to take this opportunity, once the supply is present, we can get shots in arms, that we continue the conversation around other issues that are so important to equitable access to healthcare.
Thank you. Mr. Lewis.
You know, Tony Denton answered that question incredibly well. The only thing I would add, is, the more we can leverage relationships with the community, I think the more we can quickly overcome the trust hurdle. We know trust is an underlying issue, and I think there are many many community organizations out there that have those relationships that can then bring that listening ear back to us as we think about how best to solve for this hurdle of getting vaccine in arms. So I think the more we can collaborate, the more we will hear different things from those different community organizations, and the more we can be really inclusive in terms of how we solve for it.
Thank you. Dr. Thomas, can I ask you to answer the same question?
Well, and I get this question every day, multiple times actually from my patients asking where they can obtain the vaccine. And so being able to offer them different locations, whether it's the local health department, whether it's a local pharmacy, obviously we're reaching out to our patients as well. That's been beneficial. Because we're really only able currently to reach out to our patients 65 and older when it comes to like our essential workers, we're still having them reach out to our local health department. And like I said, for others that have been frustrated because of the wait and they're kind of waiting for that ticket and that ability to sign up for the vaccine, it's nice when I can actually give them a list of different locations they can potentially go and obtain it.
Yeah, absolutely. Dr. Altman, I know that you said that, Rite is just new, here and being able to offer this to our residents, but do you have anything that you'd like to add?
Yeah, so first of all, on one of your opening slides, you had all the collaborative partners that put this program together, and I 100% screen grab that. So I have that ready to go. I think we're in a position with what we're doing that we could probably start talking about partnerships sooner rather than later with some vaccine allocation, because the way the Pfizer doses are shipping to pharmacy, they're boxes of 1,000, which we don't have ultra low freezers. So essentially, I get 1,000 doses. I need to shoot 1,000 doses in a week. Doing that in a pharmacy is not great. We can do it. We are doing it. We have stores that are doing 200 people in and out every day to get those vaccines in arms. But I think there is a huge opportunity here for me to say, in a community, is there a community partner that is deep in this African-American population that can say, Rite Aid, we're going to get you 1,000 people scheduled over these 5 days or over these 4 days or whatever that looks like. I've got the pharmacist, I've got the vaccine, let's do it. I think that to me is a quick win for us to look at saying, how can we stand something up quickly and get this vaccine moved through? And when you say what partners are out there, I am open to any suggestion, knowing that I'm always going to be limited in my size. I'm always going to have some restriction on what I can do in my pharmacy. But if it's going to a church that has a very large congregation or can call and get these people scheduled for something, we're on board. Like, I think that's our quick win. And we're doing that in some areas. We stood up a program with DHS in Pennsylvania doing just that, where we went out and gave vaccines in large events. So it's out there. I will say, if you want to contact me, you can. I get a lot of emails already, but I will absolutely figure something out and get back to you. And I think it's something we can stand up sooner rather than later to try to be very intentional with that population partnership.
Thank you. It's helpful to hear from all of you your different perspectives and what we can do to continue to build this network to be able to vaccinate folks that, particularly we're talking tonight about those in our Black community and wanting to make sure that those who want it have the opportunity to get that. And we're going to turn now to, we had lots of questions that came in prior to the event this evening. I've been looking at the questions that we have coming in and want to ask, there's some questions about decisions that were made early on, particularly from our health systems about who is an essential employee and frontline worker, and then how that has impacted the community. And what folks are curious about is trying to help understand those decisions that were made. Whether again it was identifying all employees as essential workers or the choice to do random selection for access to the vaccine rather than ranking patients based on risk factors. I'm wondering, both for Mr. Denton and Mr. Lewis, if you could particularly talk about that. I think, I know I've heard that question from a lot of people as well. Just trying to understand how those decisions got made and potentially the unintended consequences of that. Either one of you could start. Sorry.
Tony, I defer to you.
Thank you, Alonzo. Quite honestly, we followed the state guidelines as it relates to vaccine administration. Our frontline workers are right there every day, being exposed to virus potential. And so phase 1A, essential health workers, it was key and certainly recognized not only by the state, but by the CDC and its advisory committees that this is the population that should be prioritized along with residents at long-term care facilities. So we were following guidelines and believing that to be actually accurate to prioritize our workforce. I think the issue that has emerged that's been fairly well versed now is how far and how deep do you go within a healthcare organization, knowing that there are other populations that are at risk. Some of these issues are operational in terms of having to abide by guidelines set by the state, the pace within which doses received have to be delivered into arms, the interest to try to avoid wasting vaccine, and the anticipation that there's more vaccine coming, and that the pace is going to be fairly rapid, such that there wouldn't be a need to compare who should be prioritized, because everybody was being prioritized to receive the administration of vaccine within a relative time period, with priority groups having been identified. So, so that was the basis for how we administered, following state protocols, and recognizing that certainly there was a hiccup in the process. Vaccine supply went down, slowed down, and many issues around prioritization emerged.
Yeah, thanks for that, Tony. Mr. Lewis.
Well, I think Tony answered it well. There's guidance that came down, as he said, from CDC, from the state, and our health systems and hospitals needed to be in compliance with that guidance. The one good thing, I think about when we started our vaccine clinic in mid to late December, our healthcare workers, had been fighting this pandemic for months. And when we started the clinic, it was a huge shot in the arm for our organization. And it was a big dose of reality that the end was near. So those initial guidelines and waves, probably not perfect, but I think it started off the right way by giving our frontline healthcare workers the opportunity to be protected against the uncertainty of increased volume coming into our institution. And I think Tony has said it well, that I think we could be doing more, and we could be doing more effectively and efficiently if the supply of vaccine was there for us to execute more quickly and more broadly. So yeah, I'll leave it at that.
Yeah, I do think that there was the anticipation that the levels that we were receiving the vaccine initially would be continued, and then they weren't, right? And so decisions got made based on that, and unfortunately, then when that wasn't happening from the federal government, there were very real impacts for the community. Very real impacts.
Very real.
Right.
When that supply of vaccine, began to diminish a bit, we had to make decisions around not administering any more first doses, so we could actually ensure that we had enough second doses to complete the course of treatment for those who had been immunized weeks ago. And those were tough decisions for us to reconcile and make organizationally, but it was the right thing to do at that moment in time.
Sure. One of the other questions that, theme that we're seeing through the questions, is some frustration around trying to sign up, but then either not hearing back or having to sign up in a portal and, and not hearing back and being told not to call. Can all of you talk about ways to help people problem solve? Because obviously there's a willingness of folks to want to have the vaccine and want to get it. But they're bumping up against some barriers. So I'd love to hear from any of you in terms of suggestions for folks out there who are experiencing frustration in terms of either not hearing back or having difficulty with some two-way communication.
I can start. So we've definitely received that feedback, Representative Brayback, and in response to that feedback, we've implemented some different internal processes to be able to respond to folks a little bit more quickly. The biggest process is we've hired more people to answer those phones, and also our call centers in terms of messaging. So as we get messages, particularly after hours, we have more capacity now to be able to get back with those folks. I think one of the inherent in the frustration that you described, Representative Brayback, is the whole idea of communication. there's certain things that I think it's certainly been voiced on during this call, that supply has certainly impacted our ability to get more vaccination into the arms of people of color, and particularly African Americans. And I think that our county residents understand that, even though there's a limit. I think what becomes frustrating is when our messaging or our communication channels aren't open, as transparent and as early as it could be. So even if we are giving news that may not necessarily be news that our residents want to hear, in this case, particularly around supply, they still feel like they're in the know, and they feel like they're in a true partnership with the health department and other organizations who are leading the response.
Thanks, Chuck. Would anyone like, oh, I'm sorry, go ahead.
Yeah, so I was going to say I mean, this is top of mind for us because literally our appointments go live, and because the limited supply, we're only giving a week's worth of appointments at a time. And everyone has figured out in the public sort of when that magic trigger happens. And so they'll wake up first thing in the morning before anyone else is waking up. I did it for my parents myself. Woke up, scheduled the appointment, and then within the blink of an eye, those are gone. And we tried to solve that as well by standing up a call center. We piloted a program in Pennsylvania, and call center went live at 9 a.m. and at 9:02 there was 500,000 people on the phone. So it is so difficult because demand is so high to give someone a reliable way outside of an online or a virtual or digital experience. Because I mean, we didn't get 500,000 doses the entire country for Rite Aid. So for us to meet that high need and that high demand, it's really, really challenging. So part of this is doing the best you can in the moment, trying to problem solve something, which I think we all are doing, and then just being critical of it and making adjustments as you move forward and thinking through, even if a call center, that may not be the right answer, because it may be us having to call in, or it may be standing this up just as a come as you are, walk in, we have 100 doses, get there and do something like that. Like, I think we just need to really think through, with this demand being so incredibly high, you really got to be conscious and surgical with how you try to get in these communities. And I think that's our challenge right now, is none of us are getting enough doses that we can just sort of open the floodgates and let anyone come in and get it, even if the restrictions and eligibility was different.
You know, one of the, sorry, Tony, did you want to say something?
I just wanted to add on to something that Chuck said earlier. It's really important that we are as transparent with the information, whether it's good news or not, but to be real, because we want to level set the expectations so that people, they know what to do or where to turn. And so we've tried to communicate the reality and adjusted the messaging that started off with, if you belong to St. Joe Mercy Health, this is where you go. If you belong to Michigan Medicine, and this is where you go. We thought we were creating a process that was going to make it easy based on existing relationships. And then we found that we couldn't accomplish that well. And then we had to band together to say, look, the message right now is make an appointment wherever you can, that you can have a connection that's not too distant from you, because the supply is so variable and we don't want to overpromise. So that public service messaging, which you have seen in the local and national media, that basically says, no, the whole country's in the same spot. But here's what you can do to try to give people some hints of the possibilities for how they might get vaccinated. That becomes the reality as we know it now. When more vaccine supply comes out and we have sort of hardwired our approach, it'll be, I hope, easier then to move forward and adjust the messaging based on the new circumstances.
Thank you. Another theme that we're seeing, and several of you have touched on this, is, in terms of the importance of getting the vaccine out to the African American community, is partnering with our churches and pastors, right, and the Ministerial Alliance. And many of you have talked about that, and we know the importance of that. Can folks just reiterate who they're working with, or the way that you're trying to do this? And we even had one of the comments in the chat, Chuck, that the individual thinks that her mother-in-law got the vaccine from Nurses on the Run today, and it was because of a link from the pastor, like from their pastor. And so we know how vitally important that link is, and being able to partner in that way, I think will help us with the ripple effect of getting more and more folks vaccinated. So if those of you who are doing that work can just, again, highlight and lift that up, that would be helpful. Or if we haven't gotten to talk about it in a much more comprehensive way than you want to.
I'll go ahead. So our health officer, Amanda Lovelock, is meeting regularly with the Ministerial Alliance here in Washtenaw County, particularly over on the eastern side of the county. And that partnership is important for reasons that Representative Braybeck just highlighted as it relates to the comment in the chat box. But what it also does is that it impacts, we talked about vaccine hesitancy, and being able to have relationships with pastors. I think it goes a long way toward the mitigation sort of continuum of change process that has to take place for people who are maybe hesitant for some of the very technical reasons that, or I should say biologically technical reasons that Alonzo talked about. But then there's also, and I can't remember who it was that referred to the history, particularly among African Americans in this country as it relates to medicine. And so working with our pastors is vitally important. As a matter of fact, I saw one of our pastors, I won't mention who it was, who was, I saw him today, and we talked about this. And so I think it's vitally important to not only have dialogue with pastors and ministers, but also make sure that we're getting their ideas and their feedback on how we can really reach out to communities of color and African Americans in particular about the best ways to get vaccine to those in their congregations and those that live in the neighborhoods in which the churches are located. So I think it's a multifaceted approach, particularly with our churches.
That's very well said, Chuck. I think it comes down to trust and influence. The church in the Black community is that trusted place. And our pastors certainly have a certain significant influence over their congregation. And if we can partner with them and we can bring the right people into the church, I think it lends to credibility. I think it lends to trust. And I also think it sends a strong message that, we're coming to you in that community to be a resource to kind of mitigate and close this gap. So for me, it's, the Black church is probably, the biggest opportunity I believe we have. And I'm glad that we are partnering so closely with the Ministerial Alliance to think through what we can and should be doing to get vaccine in their congregation's arms. And then also to think about where we can actually effectively and safely stand up those certain sites to create greater access.
Great, thank you. Tony, did you want to say something?
The only thing I would add is that the Ministerial Alliance is such a valuable asset for us because this is not a one-off. This is part of a relationship that has continuity, and being able to rely upon faith partners in how we create a momentum means that we have to be able to demonstrate to the Ministerial Alliance that we have something that they can believe in because they're carrying the message. But they also open doors for us to be able to walk through, to be able to reach the congregation. So it really is another form of partnership that is essential for our overall community success.
Mm-hmm. You know, one of the things that Tony, you were talking about this is, you know, the importance of expectation setting, you know, and as I look through a lot of the questions, and we were talking about this before, is, you know, kind of some of that frustration that folks have run into with trying to either hear back or register. What words of advice would you offer folks if they're trying to register and they haven't heard back? How long should folks wait to kind of try and recontact to make sure that their registration didn't get, go into some technical abyss? You know, what can folks do? Like, how long should they wait before they hear back before recontacting folks?
What we have advised is that if you've received an invitation to make an appointment and you have any issue with communication, there is a number that is listed on the invitation to call in order to double check.
Great. And is there something that people can do if they don't, you know, they register but don't get the invitation yet? Is there something that folks can do to check in that system or in that place in the system?
There must be, but I can't say specifically what it is.
Okay. So maybe folks can just try and reach out again if they're not getting the invitation.
Yes.
Well, great. Thank you. I appreciate it. You know, I know that we have, we're very lucky here in our community that, folks are, wanting to be able to be vaccinated and we're trying to stand up, and Tony, you were saying this, we're building the plane as we're flying, and trying to do as much as we can and adjust, like when we make mistakes and again, and do right by our communities. And so I want to thank all of you for taking the time to talk tonight about this, answer some questions that we got from our residents. There are more questions that we did not have the time to get to tonight. Those will be followed up. Folks will be followed up with on those questions. And now I have the distinction of passing it back to Ms. Rooks.
Thank you so much, Representative Babrek. We appreciate you moderating, and to our panel members, we appreciate you as well for taking the time out of your schedule to be with us to talk about this very important information. If I could just qualify, I want to answer one question in addition to what Mr. Denton was saying toward the end, is that because we have such limited amounts of vaccine, one of the things that we're trying to do is only issue invitations for what we think we might be able to do in a week from our supply. And so we are asking anyone who has not received an invitation, either via the portal or from a letter from us, to please be patient. We will be getting to you. We just don't want to set up an expectation that will cause additional frustrations for people at Michigan Medicine. As you said, anyone, if you had so many questions, anywhere from really great questions, we were not able to get to all of them. If we have your email, we will be sending out a frequently asked questions that will cover all of the remaining questions that we did not get to. They will also be available on our different social media sites as well. And so I want to remind you, please, if I could have the slide, please, Lakshmi. There is an evaluation that we would like for you to complete in order for us to know that we are providing the correct information it's important that you fill out the evaluation. This section actually stemmed from the evaluations that we received from our first session, which has talked about African American and COVID-19. So it's very important that you provide this feedback, because this really guides our learning series, and it means we have community engagement with it. I also want to talk just a little bit about the fact that when you heard each of Michigan Medicine, Mr. Denton, St. Joe, Mr. Lewis, and Washtenaw County Health Department, Mr. Wilson, talking about the different things that each one were doing, I want to be very clear. That is a collective. We are working collaboratively on that. So we're not all doing the same exact thing. We're all at the table with community engagement. And we had one question that came in about were we just working with the Ministerial Alliance? No, actually, we are working with 3 different ministerial groups that includes the Ministerial Alliance, who banded together to create a coalition to ensure that African Americans were getting vaccinated for COVID, that they had access to COVID. And so we're working with that group as well. So with that being said, thank you so much to everyone who joined us. We hope that you heard something today that increased your knowledge and helped you become a trusted messenger for your family and friends as they are trying to make the decision about whether or not to be vaccinated. So we thank you again to our panelists and to our moderator. Everyone, please be safe.